If you're like me, then you love finding amazing deals on high quality goods. That's why I love Quince. Quince is all about luxury that's actually affordable. I'm talking 100% Mongolian cashmere sweaters from just $50. Gorgeous washable silk tops and dresses, cozy organic cotton sweaters, and even 14-karat gold jewelry. Now, you might be wondering how Quince can offer such incredible prices. Well, they partner directly with top factories, cutting out the middleman and passing those savings right on to you. And they're not just about great prices, but also about doing things right. Every factory they work with is committed to safe, ethical, and responsible manufacturing practices. And let me tell you about my latest find from Quince. A beautiful navy blue leather tote bag. And this bag isn't just gorgeous, it's super sturdy, holds everything I need, even my laptop, and is stylish on top of that. So if you're looking for top-notch quality without the high-end price tag, you really should check out Quince. Give yourself the luxury you deserve with Quince. Go to quince.com/nursemo for free shipping on your order and 365-day returns. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo. Well, hello, I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. So today we are talking about a mental health condition, but instead of just talking about it in a way that you might get if you were sitting in a lecture, we're actually going to talk about it by going through 3 clinical scenarios that really bring this condition to life. Now, the mental health concept that we are talking about today is schizophrenia. So if you want a refresher on this topic, then I invite you to go back and listen to the episode that I released just a few days ago. This was an encore episode where I actually pulled episode 81, brought it closer to the forefront of your podcast feed, and added some updated information at the beginning so that you could be up to date with your practice. So if you need to get a little bit more in-depth look at schizophrenia, then pause this episode, go back and listen to the episode I just released, or if you can't find it, it says encore at the very beginning, but if you don't see it, you can just go back to episode 81. But again, if you want that updated bit of information, you want to listen to that encore episode. Now, before we dive into today's topic, let's take a quick minute for a listener shout out. And I'm so sad because I don't have the person's name that submitted this feedback. So if you recognize yourself from this, please reach out so I can give you the credit. But this person said this: if I'm studying or on a walk or have a topic I'm needing broken down really well, NurseMo has the perfect episode. I highly recommend. So thank you to nameless, wonderful fan of the podcast. I appreciate you taking the time to submit that, and I'm so happy to be your study buddy while you are out for a walk. Alrighty, so are you ready to dive into schizophrenia? Now, as a nurse, you will be caring for patients with mental health conditions on the regular, even if you're not working in a psychiatric hospital or a psych environment. And that's simply because people with conditions like bipolar disorder, schizophrenia, OCD, depression, and anxiety also require medical care from time to time. And one of the more complex conditions you'll be faced with is schizophrenia, which again, I review in episode 81. But if you want that updated info, check out the encore episode I released this past week, so 1 week ago. So today, what we're going to be doing is exploring how 3 patients with schizophrenia can present in the clinical setting. Now, granted, these are generalities. I'm using these to illustrate the key signs and symptoms that you're likely to see and common nursing implications. Of course, all patients are unique, and I've cared for a lot of patients with schizophrenia, and in some cases, you would never know that they struggled with schizophrenia, and in other cases, it's very obvious. So I don't want you to think that I am generalizing and saying all patients with schizophrenia have these symptoms. This is just to provide you an example of what you could possibly see. Okay, so our first patient is Jacob, and he has a past medical history of schizophrenia, peripheral vascular disease, and hypertension. And in this scenario, Jacob's coming into the ER with an infected wound. So here we go. Jacob is a 38-year-old male with a known history of schizophrenia. He is brought to the emergency department by his concerned sister, Lucy. According to Lucy, Jacob has been isolating more over the past 3 weeks and been neglectful of his personal hygiene. When she couldn't reach him by phone, she visited the group home where he resides and noticed a foul-smelling wound on his lower leg, which also appeared red and pretty swollen. Upon arrival to the ER, Jacob is visibly agitated and mistrustful of the medical staff. He is heard muttering to himself and occasionally responding to auditory hallucinations, saying, "No, I won't let them trap me." His eyes dart around the room and he flinches whenever anyone comes too close, and he's clutching a worn-out backpack as if it contains something precious. His appearance is unkempt, his hair is disheveled, and doesn't appear to have been washed recently. He is wearing dark purple pants that are several sizes too large and cinched at the waist with a rope. He is also wearing a long-sleeved black shirt and a bright red jacket despite the warm spring weather. When approached by the nurse, Jacob is initially resistant, pulling away and whispering, "They're trying to take my secrets," as he clutches his backpack. Lucy provides some background information, stating that Jacob often expresses fears that people are conspiring against him. With a calm demeanor, you explain to Jacob that you're not going to take away his backpack and that Lucy can stay with him during the examination. With gentle coaxing, you finally get Jacob to consent to having his wound examined. So the physician confirms that the wound on his leg is indeed infected. The wound is cleaned and dressed, which, can be a pretty painful procedure, though Jacob did decline analgesic medication due to his suspicions. Treatment options are discussed with Jacob and Lucy at length, and Jacob repeatedly questions the purpose of medications, suggesting they are part of a plot to harm him. It is ultimately decided that Jacob will be admitted to ensure adherence to antibiotic therapy. The physician also orders a psychiatric consult. So the psych NP comes to see Jacob and recommends adjusting his antipsychotic medications while emphasizing the importance of follow-up with his outpatient psychiatric provider. Since Jacob is being admitted, he will need to have his backpack searched so that we can make sure there's nothing in there that could cause harm. You enlist the expertise of the psych nurse practitioner to navigate this potentially difficult situation. You ensure Jacob can see everything you are doing as you look through his backpack and catalog his belongings, and he is ultimately safely transferred to his room on the med-surg floor. Okay, so looking back at Jacob, you can see that a lot of complexities with his care, challenges with interacting with him so that he feels safe and supported. He's obviously very paranoid and displaying a lot of signs of paranoia. So enlisting trust, right? Keeping the sister at the bedside, approaching with a calm demeanor, explaining everything, making sure he can watch as you look through his backpack. All of those things help to kind of assuage his suspicions and his paranoia so that Jacob can get the care that he needs. So our next patient is Daniel, and he has a past medical history of schizophrenia, pancreatitis, and type 2 diabetes. And in this scenario, he is brought into the ER because of a change in level of consciousness. So here we go. Daniel is a 42-year-old male with a diagnosis of schizophrenia with catatonic manifestations. And he is brought to the hospital by his caregiver due to a concerning shift in behavior. According to the caregiver, Daniel had exhibited increased purposeless movements for several days, but had suddenly become completely immobile for the past 10 hours. She states, "He was just pacing and repeating everything I said a few days ago, and now he won't move at all." Upon arrival, Daniel is found sitting rigidly in a wheelchair. His gaze is fixed and unblinking. Despite all the activity going on around him, Daniel remains completely still. His caregiver is deeply worried, explaining that Daniel hasn't had anything to eat or drink since becoming immobile, and that his intake prior to that was minimal due to his increased purposeless movements. She tells you he has not responded to any verbal cues or physical touch since early that morning when the shift in behavior was noticed. The medical team quickly obtains a set of vital signs, which are heart rate 128, blood pressure 188 over 57, respiratory rate 28, SpO2 95% on room air, and temperature of 98.5. A quick assessment reveals dry mucous membranes and poor skin turgor, which further support a diagnosis of dehydration secondary to the patient's schizophrenia and their catatonic state. You attempt to start an IV, but it is very, very difficult due to Daniel's rigid posture and resistance to being moved. You take care to approach Daniel gently and speak in a calm and reassuring way to minimize any distress he may be feeling. With the help of another nurse, you're able to start the IV and initiate fluid therapy to address the dehydration. You obtain a blood glucose level and are relieved to see Daniel is not hypoglycemic, though he is on the lower end of normal. Labs are drawn to assess electrolyte levels and renal function, which you suspect to be impaired due to his hypovolemic status and poor nutritional intake. Daniel is admitted to the med-surg floor for continued hydration therapy and support. As you're preparing Daniel to transfer to his room, you know his care is going to present some specific challenges to the nursing staff. So one of those is communication difficulties. Daniel's catatonia presents significant barriers to communication. His lack of verbal response and his immobility will require the staff to use alternative methods to assess his comfort and his pain levels. For example, the nurses may need to rely on physiological cues, such as changes in vital signs, to determine if Daniel could be experiencing pain. Another challenge is physical management. To prevent injury, Daniel must be handled very carefully. Because he is resistant to movement, it's important the staff don't use excessive force, which could cause harm and create an environment of distrust. Now, to preserve mobility, passive range of motion will be necessary, which can be especially challenging with the patient displaying catatonia symptoms. Another challenge the nursing staff may face, or definitely will face, is pressure ulcer prevention. The risk of pressure ulcers from prolonged immobility is high for Daniel. And this risk is made even higher, not just because of the immobility, but because of his poor nutritional status. So he will require aggressive skin protection interventions and frequent repositioning. Another challenge is nutrition and hydration. Since Daniel is not responsive, he's not taking in any food or water on his own. He's going to require IV fluids for hydration, and he will also likely require enteral nutrition. Now, assuming that is ordered, then the nurse will need to insert a nasogastric tube and initiate tube feeding to provide Daniel with adequate calories. And then another challenge could be blood glucose management. Daniel is at high risk for impaired blood glucose, so it will be very important to monitor this routinely. Since he will likely be on continuous tube feeding, his blood glucose will likely be measured every 4 hours to ensure his levels are stable. If he weren't going to be receiving tube feeding, if for some reason the physician wanted to wait a little bit before initiating that, then he may or she may order some fluids with dextrose in them to provide some blood glucose management. And if you can hear that meowing, that is Oliver coming in to say hello. Let's take a quick break, and then when we get back, we will talk through patient Emma. When it comes to grocery shopping and meal planning, I've got a bit of a problem. It's time. Time is the problem. And when I don't take the time to plan ahead or go to the store, guess what happens? Cue the takeout. But Hungry Root has changed all that. It really is the easiest way to eat healthy. Hungry Root is like having my own personal shopper and nutritionist all in one. They make recommendations based on my preferences and my health goals, and all I do is go online, click, 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 and like magic, my groceries show up complete with recipes that can be made in 15 minutes or less. They also have other healthy options like smoothies, snacks, ready-to-eat meals, and my favorite, the salad kits. I made a goal of eating more salad this year, and Hungry Root has made it so easy. You're going to love Hungry Root as much as I do. Take advantage of this exclusive offer. For a limited time, get 40% off your first box, plus get a free item in every box for life. Go to hungryroot.com/nursemo and use code nursemo. That's hungryroot.com/nursemo, code nursemo to get 40% off your first box and a free item of your choice for life. hungryroot.com/nursemo, code nursemo. Okay, with our final patient, we have Emma. She has a past medical history of schizophrenia, cholecystitis, and breast cancer status post-mastectomy. And in her scenario, she has had an intensification of symptoms while in a psychiatric hospital. So Emma is a 59-year-old woman diagnosed with schizophrenia who has been residing in a mental health hospital for the past 2 weeks due to an increase in symptoms while her medications are being adjusted. Her symptoms recently intensified further, necessitating her transfer to the intensive care unit of the psychiatric facility. As you review the nursing notes, you notice that Emma's disorganized speech and behavior have been quite pronounced. So here are some things that you saw in the nursing notes. 1, Emma has been observed pacing back and forth in her room, occasionally stopping to mumble or laugh without any apparent stimulus. She's also had speech that has been largely incoherent, characterized by word salad, making it very difficult for the staff to understand her needs or her emotions. You also see in the notes that Emma at times exhibits a flat affect, showing little to no emotional response, and her interactions lack appropriate facial expressions. Emma occasionally uses rhyming, saying nonsensical things such as, "It's time for lunch, crunch the flump stump," or "The sun is out, spout the snout, that's what it's all about." Also, you see in the notes that Emma has been extremely distrustful of staff, especially anyone new. This has resulted in a core team being involved in her care. The notes state that yesterday, Emma started screaming in the common room, shouting, "Snake, snake, snake," over and over while pointing to a tree branch that was just outside the window. In another note, you see that Emma began laughing uncontrollably when another patient fell in the common room and injured her leg. And on more than one occasion, Emma has invited staff members to the White House, where she serves as press secretary, and has stood in front of the common room to issue press briefings that are an amalgamation of grandiose statements, word salad, and tangentiality. Now, all of these things are things that I actually did experience as a nursing student doing clinical rotations in the intensive care unit of a psychiatric hospital. So just kind of pulled together all the different things I saw and put them into this clinical scenario about Emma. Just because I know that some of those things seem a little bit off or a little bit out there, I want you to understand that when a patient is having intense schizophrenia symptoms, their behavior can be quite unusual. And I just want you to be prepared for that should you be in that situation. So, as you can see from the things that Emma has been experiencing, she has had some pretty disorganized speech patterns and some pretty disorganized behavior. One of those things is word salad that I mentioned, and that is where the speaker just inserts random words, things just don't make sense, and speech for a patient experiencing word salad type symptoms is going to be pretty incoherent. One of the other things that she is displaying is flat affect and a lack of appropriate response or emotional response. When another patient falls, she laughs uncontrollably. That's an inappropriate response. What about that rhyming thing that she was doing? The sun is out, spout the snout. That's what it's all about. Or saying things like that. That is called clang association. So you may see that on an exam. She also thinks that tree branches are snakes, so she's having some delusions about that. And she also is displaying signs of grandiosity or grandeur, where she truly believes that she is a White House press secretary. So this is a scenario where Emma has had quite an intensification of symptoms. So what are some key nursing interventions that we would employ during Emma's hospitalization? So one of those is constant supervision. That's why she is in the intensive care unit. She is under constant supervision in this high risk or high acuity care area that ensures she can get immediate or very, very prompt intervention if she engages in any inappropriate behavior or potentially harmful behavior. We also want to make sure we are in a safe environment. Emma was moved to that intensive care unit to minimize risks as there are fewer potentially harmful objects and a more structured environment. We also want to make sure that interactions with Emma are non-confrontational. We want to make sure that as staff, we approach Emma in a non-threatening manner. We maintain a calm voice and non-threatening body language. And we also want to keep Emma rooted in reality as much as we can. Okay. So when Emma says and shouts, snake, snake, and points out the window at the branch, we're not going to say, oh, Emma, let's get you away from the scary snake, because that just reinforces her delusion. Instead, we want to say something like, I understand, Emma, that you are seeing a snake outside the window. I am seeing a tree branch. There aren't any snakes here, but I understand that you are seeing a snake, and I don't want you to be frightened about that. So why don't we move over here to the other side of the room? So with that, you are acknowledging her reality, which her reality is that she is seeing snakes, but you are letting her know that that is different from your reality and what is actually happening. So that is a very key component of therapeutic communication in a psychiatric setting. And then another thing that we want to do is get Emma engaged in activities. Emma would be involved in very simple, very structured group activities in that environment that don't necessarily require complex social interactions, but do allow some level of engagement with other people. This approach helps facilitate our ability to monitor her social behaviors and see how she does as her treatment plan is adjusted and her medications are adjusted as well. So there you have it, 3 scenarios where you might see a patient with schizophrenia and how that affects their care in an inpatient setting as well as in a psychiatric facility. If you are in nursing school, I do hope that you get a robust mental health clinical experience. I learned a ton working with these patients, and I don't work in a mental health facility. I work in an acute care hospital, but guess what? I work with patients with mental health conditions all the time. And if I had not had any exposure to individuals who have schizophrenia, who have OCD, who have bipolar disorder or anxiety or depression or, the myriad mental health conditions that are out there, then I would be at a bit of a loss on how to deal with that in the inpatient setting and provide well-rounded, holistic, patient-centered care. So if you have not yet started your mental health rotation, if you're in school, it is definitely something to look forward to. And if you're listening to this episode on the day that it comes out, happy Valentine's Day Eve to you. I want you to know that I love making this podcast. I love helping nurses and nursing students. And if there's anything that you would like to hear on the podcast, please send an email to team@straightanursingstudent.com. And we love getting your suggestions. We often incorporate them into the podcast. So please, if there's something I haven't yet talked about and you're wanting to hear it, I'd absolutely love to hear from you. So if you're not yet following the show, please do so you don't miss an episode. We do have Monday little short, quick episodes now, and I'd hate for you to miss any one of those. And I will see you back here again very soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Have you ever wished that you had a direct line to your pediatrician to ask all the questions that constantly crop up while parenting? We sure have. That's why we launched the Bites of Health podcast. Every morning, we'll answer a commonly asked pediatric question in 5 minutes or less. You can tune in while you're making your second cup of coffee or from the school drop-off line. So be sure to tune in to Bites of Health, streaming now.